On to the results. We start off with the people who had a clinical label of type 2 diabetes. There were nearly 300 of those people who entered the study. And altogether, in those people who had not been suspected of having MODY mutations before, we found 12 mutations, so 4% overall. And just breaking it down into those different groups that we defined at the beginning, only 14 of those patients fitted classical criteria for MODY testing, so arguably should have been tested before. And in that, 5 of those mutations were found in those people. So it's a very high pickup rate of about 35%, but it's only a small number of the number of people in the collection. If we take the criteria a bit wider and just look at those with young onset, and there's no other criteria at all, family history is not important, or obesity or anything, this represents about 13% of the overall collection. And in those people, we found 8 mutations. So it's still a pretty good pickup rate of about 20% of those people. If we take it out to all those diagnosed under 45 who don't have metabolic syndrome, this is more of the patients. It's about 20% of the patients. And we found 9 mutations, so about a 15% pickup rate. So overall, because there's overlap in the groups, we ended up sequencing 82 people, so about 30% of the whole group. We found 12 mutations, as I said, so about a 15% pickup. And the thing to notice here is that if you have the extended criteria, you more than double the number of MODY cases you find, but you have to do 6 times as much sequencing. So this is where the cost implications come in. So just an example of the sort of patient you pick up by using this method. So Sally, who was 45, so right at the top of our age range, and she'd been diagnosed with type 2 diabetes the year before. She was lean with no signs of insulin resistance. She already had very good glycemic control on what the standard first-line treatment for type 2 would be, so metformin. She had no family history, and she was found in our study to have an HNF1 alpha mutation. We sent her off on 40 milligrams of gliclazide, and she had a hyperglycemic episode on the subway on the way to work. But she forgave us and now takes 20 milligrams of gliclazide, a quarter of a tablet, and dropped her HbA1c further without hypoglycemia. So, you know, she's done very well. But arguably, there may be quite a number of these people out there who would never be tested. To go on to look at the type 1 cases, so we started off with just under 250 people who had a clinical label of type 1. And in those, we found, well, I've got here, we found 2 mutations. We've actually subsequently found another mutation. So it's actually 3 out of this group of people, but originally we only found 2. Oh, no, here we are. Sorry, I've changed it on this one. So, so we ended up sequencing. We ended up finding that about 9% of the group had significant endogenous insulin secretion based on those criteria. And as I say, we've eventually found 3 mutations. So about 1% of the group altogether and 14% of the people that we sequenced. So there's some obvious limitations of this study. We are still sequencing selected groups. And we think they're the ones with the highest chance of having HNF1 alpha or 4 alpha MODY. And we assume that we can't really be sure. And just coming back to the question from the session before, if we look at Jason, who's now age 37, he was diagnosed with type 2 at the age of 27. So he was included in our study because he was diagnosed under 30. But he's obese, with a big waist circumference. He's not hypertensive, but he did progress quite quickly onto insulin after only 3 years. So he took sulfonylureas, and he wasn't sulfonylurea sensitive. He's got a family history. His half-brother's got type 2 diabetes, and he was found to have an HNF1 alpha mutation on the basis of his age of diagnosis in the study. What we found was that his mother, although she was 57, she did have diabetes, but she wasn't aware of it, and she's got the same HNF1 alpha mutation. But his half-brother doesn't carry the mutation. He's a phenocopy. He's got type 2 diabetes. So, again, how many of these people are out there, we don't know. And it doesn't matter so much to Jason that we make the diagnosis because we can't change his treatment. But obviously it matters to his mother and other family members, so still important to find them. Obviously, when you diagnose a genetic condition, you then have to go out to the families, and that's a lot of work. So from 15 MODY subjects found, we got 10 additional mutation carriers, and we're still investigating other family members as it goes on. There were 2 newly diagnosed diabetics in that group, and 1 new impaired glucose tolerance. We also found 3 non-diabetic subjects, diabetic subjects without the mutation. And treatment changes, if we take 23 of the people, a large number of them were either already on sulfonylureas, or they didn't need treatment, or they'd already progressed through sulfonylureas and were unlikely to benefit. But we did, 7 of them did have a trial of either sulfonylureas alone or a sulfonylurea added to insulin, and we showed an improvement in HbA1c at 3 months in those people, and nobody did worse, so it was beneficial. So to summarise, altogether we found 13 HNF1 alpha and 2 HNF4 alpha mutations, which was 4% of our type 2 group and about 1% of our type 1 group. Only a third of those cases actually met standard diagnostic criteria, and from those we found 10 additional mutation carriers, and 30% overall had a treatment change. And just to say that if you do look hard for monogenic diabetes, you do increase the prevalence in your local area. So we now have about 60 cases per million of HNF1 alpha, 4 alpha. So I think what I would just finish off by saying is that what we're looking for is to find the people with young onset diabetes that's C-peptide positive, probably antibody negative. It doesn't matter what their existing label was, that we have to somehow find those people and do genetic testing on them. Thank you. I'd just like to acknowledge everyone.
Katrin, thanks a lot for this wonderful presentation, and we have a few minutes for the questions. Tomek.
Thank you for your presentation. My question concerns those type 1 diabetics who finally turned out to be MODY mutation carriers. I'm thinking about easily clinically available data that could help us in somehow selecting people for further molecular testing. Do you have any information on their insulin per kilo dose? I mean, what, or any range of this insulin per kilo dose?
I think that can be a clue. I mean, I think the short answer to that question actually is no, because if I think about the people in my clinic who had a previous label of type 1 diabetes, in most cases that was not suspected at all from their clinical features. And yes, probably 1 or 2 of them had lower insulin doses. So if they do have a lower insulin dose, that's a clue. But for instance, the lady on my first slide, Leanne, she was extremely over-insulinized, so she was taking 1 unit per kilo, and she put on a lot of weight with that. So if it's there, it's helpful. But I think there are lots of people out there who you wouldn't be able to tell, and the only real way of doing it is by thinking about measuring C-peptide in people and putting it into the early diagnosis pathway, so that if you watch C-peptide not declining as time goes by, that's a non-specific test, and it's not very useful close to diagnosis. So what we're really lacking is something which helps differentiate those people who are given a label of type 1 close to diagnosis, because they have years of insulin treatment that they don't really need. So.
Thank you very much. Any more questions? Katrin, you showed the newest data concerning the prevalence of MODY from Oxford region, I'm assuming. So if you extrapolate this new data into the entire UK, so you are bringing up the minimum number of MODY patients to what? 15,000, 20?
Actually, from our data, it's so we've done this. We've looked at this in a primary care community-based setting, and what we found is, and we only found. Sorry, I'll start again. We looked in 12 GP surgeries, so there was around Oxfordshire, and the cases we found were only HNF1 alpha cases. We didn't find any glucokinase or HNF4 alpha, but presumably because they're rare and our baseline numbers were not that big. And we only had about a 30% response rate to the study. So it wasn't we didn't test everybody. We used the sort of criteria that I talked about in this study, you know, wider criteria. And we found, and we also included family members who were in the same location. And we found about 80 per million of HNF1 alpha in a 30% pickup rate. So it could be anything from, you know, anything up to 3 times greater. But that's still only about 5,000 or 6,000 people in the UK. But if you say it could be 3 times bigger, then...
Exactly.
Yeah.
And so that's not the end. And any more question? One more. I'm sorry. One more. Because basically you used C-peptide as a kind of biomarker to differentiate between MODY and type 1. And I fully understand that you did not include the other biomarkers because we will have time for that later on during this course. However, after the new discoveries, your discoveries, is there still a place for C-peptide and glucagon test having such a tool as CRP in hand?
Well, I think that I think the answer to that is yes, because I think you want to, as I said at the end, define your young onset patients who are C-peptide positive, because there's very good evidence that certainly for the commoner types of MODY, 1 alpha, 4 alpha and glucokinase, their C-peptide is in the normal range. And if we're saying that only about 1% of people with a clinical label of type 1 are going to end up having HNF1 alpha, if you can rule out from your established type 1s a lot of those cases who are C-peptide negative, then I think it does still have a role.
Okay.
Absolutely.
Thanks a lot. Any more questions? If this is not the case, thank you very much, Catherine. And now I would like to introduce